My name is Michael Savin. I'm a hematologist and a medical oncologist, meaning I'm a physician who's a specialist in hematology as blood diseases and in cancer. And I've spent a good part of my career, particularly recently, concentrating on cancer of the breast. I grew up in San Francisco, California, traveled around the country for my education in college and medical school, spent some time at NIH, and was in academic practice for a long time, teaching medical students, doing research, then spent 29 years in practice with a large oncology group called Texas Oncology. For the past couple of years have been in Portland, Oregon, doing breast cancer at the Oregon Health and Science University. Well, as a child, I thought I'd be a musician for a while. I became interested in medicine through the father of a friend who was a physician who got me a job working with a doctor when I was in high school, working with a doctor in San Francisco where I grew up. And they had a very active program with research and clinical care, and they integrated me into it as if I were a medical student, although I hadn't even yet started college. And that kind of began my trajectory that led me to go through college, medical school, and in medical school, like most medical students, I wanted to do a little bit of everything, but I knew I didn't want to be a surgeon. That was the easiest thing for me to tell. But ultimately, I focused first on hematology, which at that time was very scientifically grounded, a very interesting and engaging field where you could do clinical and research work, and oncology. The treatment of cancer patients especially grew out of hematology. So I sort of evolved into it over time and went from doing primarily hematology and then hematologic malignancies into doing cancer care in general. In the last few years, I've focused on breast cancer. And actually, since I've been in Portland, that has been my exclusive focus in terms of my own practice, which is the care of patients with breast cancer and research on breast cancer. Well, I grew up, there were no physicians in my family or any healthcare people. My father had a shoe store in the Haight-Ashbury in San Francisco during an interesting time. But I went to college thinking about being an academic or thinking about medicine, and eventually focused on medicine, went to college in Boston, medical school in Pennsylvania, then did internship and residency at Duke University, some time at the National Institutes of Health, and then I actually came to Seattle, Washington to do a fellowship in hematology initially, in blood diseases, and then out of that evolved into care of cancer patients. First, patients with leukemias and lymphomas and what we call malignant hematology, and then from there evolved into solid tumor cancer. I went from training in Seattle to being on the faculty at the University of Kansas, and then at New York Medical College, then at Eastern Virginia Medical School, and then moved out of academic practice into an academically focused private practice based in Texas called Texas Oncology, which has evolved into a large group called US Oncology. And I spent 29 years there taking care of patients with a variety of kinds of malignant diseases and blood disorders. But over the years in Dallas, I focused more and more on breast cancer, became more and more involved in care of patients with breast cancer and clinical research in breast cancer. And then as our family grew and our kids, by various routes ranging from Europe to Australia, migrated to the Pacific Northwest, my wife and I also did. So we've been here about 2 years. My wife is a lung physician in private practice, and I'm an oncologist here at the university in Portland, now focusing exclusively on breast cancer. Well, I went to medical school, graduated medical school in 1969. So that's really the start. After that, did internship and residency at Duke. I spent a couple of years in the laboratory at the National Institutes of Health, and then moved on to the specialty training, initially in hematology and then hematology and oncology. That was at the University of Washington. That was really the focus of my evolution into cancer care. Well, oncology is complex in many ways. A part of what we do is diagnostic, not just in the sense of making a diagnosis of cancer, but also characterizing, as particularly these days when we have very sophisticated biochemical, molecular, and various other kinds of tools to evaluate patients with cancer. We define the cancer as best we can and define its characteristics in a way that allow us to both look at the prognosis and see what the prognostic factors are, and also to identify treatment tools that are appropriate for a specific patient. So for instance, with breast cancer is not one disease, it's a whole family of diseases. And we look at things like what parts of the body are involved. Looking at the cancer itself, we look at some of its molecular characteristics. For instance, does it still retain the hormonal receptors that normal breast tissue has that allow it to interact with hormones, because those become targets for treatment. We look at things like what cell type it is. We classify them into broad groups that have to do with molecular characteristics, growth characteristics, and again, help us define prognosis and help us define treatment. That's a tough question. The role of technology in the care of cancer patients has evolved. Looking specifically at breast cancer, a part of the technology is diagnostic technology, and that includes what we call diagnostic imaging. In other words, X-rays, mammography, that kind of thing, and ultrasound, which is a type of imaging that uses sound waves rather than any kind of radiation. MRI scanning, that stands for magnetic resonance imaging, which doesn't use any form of radiation but just looks at the magnetic fields around individual molecules in hydrogen atoms, actually, inside of tissues to create images. So that's one aspect of technology. A second diagnostic aspect of technology is what we can do with the tissue. When we get a biopsy of tissue, we can look not just at what it looks like under the microscope, but we can look at whether or not it expresses hormone receptors, which can help determine treatment, whether there are specific molecular markers that may direct us to using certain kinds of agents. We can get a good idea of what kinds of things it may or may not be sensitive to. Yet another area of technology is in therapeutics, which includes the technology involved in development of new drugs, which has gone from just kind of taking things from plants and testing them in different situations to very sophisticated tools we have now to actually create chemical molecules that target very specific molecular structures inside of the cell so that we can treat cells that have very detailed specific characteristics. That involves extremely sophisticated technology. And technology for things like radiation therapy. We used to do radiation therapy by generating a sort of broad area of radiation that would be pointed. It's kind of a point and shoot, terrible term for it, but where we would end up giving a lot of radiation to surrounding tissues. Now we have very sophisticated ways of delivering highly precise radiation to highly precise spots and areas. So it's really quite remarkable. That's a kind of nuclear technology evolution. So we have biochemical technology and nuclear technology, imaging technology, all these areas. On the surgical side, there are many tools that the surgeons have now where, for instance, with breast cancer, the surgeon will use a tool to identify which lymph nodes under the arm are the first ones that cells are most likely to go to from a cancer in that breast. And once they identify those, they can remove them at the time of a biopsy or excision of the primary tumor nodule to see if they show any evidence of spread of the cancer, which can help determine later treatment. We all have ethical concerns in every profession. Probably the first and single most important one is to ensure that we maintain absolute privacy for patients. There is something called HIPAA, HIPPA, which basically refers to the right of patients to have their information protected. Protected from access by any unauthorized source, whether it's a government agency, a police agency, a curious employee in a hospital who goes in and tries to look at their medical record to get information. But I think that's probably one of the first and most important ethical issues is the maintenance of privacy and respect for privacy. The second is the next element of that respect issue is respect for the individuality of a person. You know, that you have to accept that person as they are and as a human being, and not just, they're not a laboratory animal that we're just going to do something to. So we have to respect that they have the right to make their own decisions. You know, my job as a physician is to try to analyze a situation, come to some sense of what I think is an appropriate way to proceed, whether it's with diagnosis or treatment or some combination, and then present that to the patient. But it's their decision to make. It's not my decision to make. And I think sometimes it's very easy to think, well, I know what the right thing to do is about this, and just kind of charge ahead or become unintentionally coercive. That's an ethical flaw. I think I see that as an error. You know, I think the right thing to do is to provide people with enough information, respecting what they're able to understand and not understand, and making it as clear as possible and as unbiased as possible to allow them to make their own decisions. And then when they do make those decisions, it's not uncommon for a patient to make a decision that I completely, or the treating physician completely disagrees with, a decision not to accept treatment, or a decision to not accept a particular diagnostic study, or the desire to place limitations on treatment. And it may radically differ from the way I see the problem and what I think is the best thing to do, but it's their decision to make and not mine. So that's an important ethical issue as well in medicine. The most important thing is to try to provide information to patients and their families. The families included to the degree that the patient wants them to be included. To do everything you can to make it comprehensible to them and accurate enough without pushing them to make the decision you want them to make. And that's a lot harder than it seems, because as physicians we often believe that we have the right answer for them. Human nature being what it is, you want them to follow your guidance so you can, without even realizing it, sort of pull the information flow in the direction that tends to draw them to what you think they should do. It's okay to do that as long as you do it recognizing that you are giving your bias, and even acknowledging to them that I'm telling you what I think is the best thing for you to do. You're the only one who can decide what's the best thing for you to do. I'm shorter than most of them, I think. That's a good question. I'm not sure what the right answer to that is. I think you know, we all have different approaches to things, and I don't think there's a right or wrong approach. Before I came to Portland, I worked with a group. We had a group of doctors who worked very closely together. We were part of a group, saw similar patients, and we all had different personalities and different approaches. I think that my obligation is to just be myself. And for some patients, that's the wrong mix. And I think it's important when that happens to be able to support the patient in their moving in a different direction, or at least to a different provider who is able to meet their needs and communicate with them more effectively. It's interesting, if you look at reviews that patients do of physicians, you know, each of us as physicians tend to have opinions about other physicians and how they interact with patients. But when you look through these reviews, you'll see that people react radically differently to it. You know, you'll have a series of reviews, and to one, you know, for the same physician, patients with similar issues, one of the patients sees them as somebody who is open and understanding and accepting of their views and really able to incorporate them into the decision making. And the next person writes a review of that same physician, same disease system, same approach, says, this guy hasn't got a clue how to communicate with me. He doesn't listen. He has no concept of what life is about and what my life is about, so nobody should go see him. It's an interesting situation. It's very personal, and I think you have to be willing to acknowledge what you bring into it in terms of bias and, you know, sort of prejudgment, so you can, to the extent that it's possible for anyone to do that, so you can put that aside. In terms of, you know, I don't know that I had one mentor. When I was young, when I was in high school, This kid I went to high school with, his father was a physician, he was a pediatric cardiologist, and I started to, through knowing him, I kind of expressed some interest in medicine. So he put me in touch with a cardiologist in San Francisco that I ended up working for in the summer for the last year before I started college. And he became a mentor, actually. He was a guy named Arthur Selzer. He was actually an internationally renowned cardiologist. I didn't know that at the time. He was this interesting guy from Europe. He took me under his wing. I mean, he thought it was fascinating. I think I was the youngest student he'd ever had because I was a high school student, you know, working with him in cardiology in the hospital. He took me into the cath lab. I met the patients. He taught me how to read EKGs, and I worked with his trainees. He had a lot of fellows that he was training, so I ended up reading EKGs with him. That got me very interested, and he reappeared in my life when I was on the faculty at the University of Kansas Medical School in Kansas City, and he came as a visiting professor. He found me there. He remembered me. He'd actually helped me with getting into medical school. So he ended up spending most of the visit. He was supposed to be talking to the cardiologist there. He mostly wanted to talk to me and my life and what I was doing. So he was my only real early mentor. I also had a powerful mentor when I was a fellow at the University of Washington in Seattle, and that was a fellow named Clem Finch, who was the head of hematology there. And even though he was not involved with malignancy so much, he was just an amazing man. He was a role model for me, and very warm, very straightforward, brilliant guy but he treated everybody the same, everybody with the same respect. If you were the guy who swept the floor, he treats you the same way. And in fact, when we had fellows there, he had this beautiful big office. He gave up his office so the fellows could have it and moved into what had been a closet to make a little tiny office because he said, the fellows need this space. You know, I don't. We have trainees here at the program that I'm at, and I enjoy interacting with them. So I hope that I'm able to be a little bit of a mentor for them as well. But I'm not unique in that by any stretch of the imagination. We have a lot of people here who are wonderful mentors for our trainees here. That's a very tough question. Part of it is, it's the traditional hard work. I mean, but we all work hard. I don't know anybody in medicine that doesn't work hard. I think you have to really have a passion for what you do. And when I say passion, part of that is drive kind of passion. You want to be successful, and that's one kind of drive. But the other kind is you have to really kind of lust for the information. I mean, you have to really want to know more and want to see more patients. And you also, I think, have to want to, at least on the clinical side, when you're doing clinical care, it's different with laboratory research where the passions are different. But you have to really want things to be good for your patients because you become the vehicle for their getting care, or at least a part of the vehicle for their getting care. So you have to really care about it. And doing that, I think, makes you more successful as a physician in general, and I think also makes you more able to be successful in the specific areas that you're addressing, whether they're research areas or clinical areas or a combination. I think the best advice I can give someone looking at a career in medicine in general is you can look at it as a job, but it's not just a job. And if you do yourself a disservice and you do your patients a disservice. I mean, I think you need to have a tremendous desire to learn new things because medicine changes so quickly you can never stop learning. The worst thing that happens to people in any profession, I think, is they get into their profession, they begin to become successful, and they stop learning and stop growing. And you can enjoy it and be successful, but you lose something. And I think if you want to have a meaningful impact on any aspect of healthcare as a physician, you have to continue to care, continue to learn, and continue to be invested in the self-knowledge that you don't know everything. Well, I think it kind of goes back to what I was saying even just a few minutes ago. I think the thing I can share that may be more important than anything else I can say is you have to love what you do. You have to be able to generate something other than just the sense of I'm going to work, to make a paycheck and come home. Because if you do that, at some point you'll burn out and you'll lose satisfaction, you'll lose warmth and value in your life. And I think, and I don't think it matters what kind of work you do. I think there's value in everything that everybody does. You have to just allow yourself the opportunity to recognize it and acknowledge it, because then you can be fulfilled. Thank you for joining me today. If you would like to know any more about oncology or about breast cancer care, please feel free to contact me. I'm at ohsu.edu, or you can call me at 503-494-5672.